I'd like to introduce Simon Craig, who is you, isn't it?
It is me.
Yeah, good. You look surprised. Simon is also a member of Predict and is a very clever man and likes to come up with lots of ideas. And I'm a bit excited to hear what he's going to talk about now. He's going to talk about some opportunities in digital health.
Thanks very much, Meredith, and thanks both for the organising committee arranging the conference, which has been fantastic, but also for the opportunity to speak here today. Digital health is sort of an interesting topic, and it sort of does cover everything, everywhere, and potentially all at once, depending on how you're set up. So thinking about your last shift at work, whether you've got an electronic medical record or whether you don't, did you do a good job? And how can you measure that? How can you tell that you did a good job or not? Did your colleagues do a good job? And these are it's an interesting question. And the answer isn't necessarily straightforward, but it's an answer that's worth exploring a little bit. What is your job? I mean, you're a doctor, you're a nurse, you're a physio, you work in an emergency department, you work on the paediatric ward. Our jobs are lots of different things, and if you're sort of a fairly senior doctor, you spend a bit of time on individual patient care, and that involves making decisions and making diagnoses, communicating, but you also spend a lot of time thinking about everything else in the emergency department, so managing flow, teaching and supervising people, keeping it nice, keeping it safe. So there's lots of things. Whereas if you're a more junior member of staff, all your patient care stuff is still there. Your contribution to managing the ED is trying to get your stuff sorted and under control and still keeping it nice. But then how can you actually tell that you've done a good job is one of these questions that does bug me a little bit. And you can ask a couple of people, but it's not necessarily the best thing to do. Is the health system doing a good job? If you look at any of the papers at the moment, there's quite a lot about the healthcare crisis or the crisis in our public hospitals. These guys, the Australian Government, the Productivity Commission, the Australian Institute of Health and Welfare, measure things to try and tell us whether we're doing a good job at a systems level, at a hospital level. Australia spent $76.7 billion to fund public hospitals in the last report that's available. It's quite a lot of money. And when they're trying to measure what they get for this money, these are the things that the government and therefore us as a society think are important. We're looking at access, we're looking at equity of access, we're looking at appropriateness of care, quality, safety, responsiveness and sustainability. These are all big words, but what do they actually mean? How do you measure these things? We'll just pick a couple. Think about how you measure appropriateness of hospital services. You're all clinicians. How would you measure whether your service is being provided as appropriate? And how do you measure avoidable mortality? And Jason touched on that earlier. Death's pretty rare in paediatric care anyway, which is good. But we'll just focus on these for a minute, and I'll present to you the definitions that are provided. So the Australian Government Productivity Commission looks at appropriateness of hospital services and defines it as such. So appropriateness of hospital services is an indicator of government's objectives to provide care that's appropriate and responsive to the needs of individuals throughout their lifespan. How do you measure that? Well, currently, the way we're measuring it is whether someone leaves against medical advice. It's not a great measure of appropriateness of hospital care, but that is the government measure of appropriateness of hospital care. There is a long spiel about avoidable mortality in hospitals, but what they actually say is that we don't actually have any data. So these are sort of important things. So if we're spending billions and billions of dollars, we're not really measuring whether the care we're giving is appropriate in any meaningful way, and we're not really sure whether there's avoidable mortality. And we've got this problem at the moment that we are measuring stuff, but we're busy measuring things that's relatively easy to measure and not really measuring things that's particularly important. So why measure things? I mean, really, the reason I do research is because I want to make stuff better. I want to do things that will make what I do day to day better than what they were before I did them. And so trying to improve performance and understand performance is a big part of what research is. But you can look at an individual and your own performance and reflect on that. And you can look at a health system or a hospital and look at that performance and reflect on that. But you need to be able to measure things to be able to work out whether you're doing a good job or not. We can measure things for research, and I don't like doing research for research's sake and trying to fix things and make something better. Right? Knowledge translation. Have we found something that's awesome, makes a difference, and then can we get that into practice? Can you measure that? Of course you can. And things cost money. So are there things that we should be spending more money on? Are there things that we should be spending less money on? So really what it comes down to, are we measuring what matters? And we've mentioned what is your job, and we'll talk a little bit about individual patient care and evidence-based care. Now when we're measuring care, you can really look, the care for someone with a sprained ankle is different to the care you provide with someone with bronchiolitis, which is different to someone with a head injury, right? But really, in the context of the health system, the things that we can measure are things that are written down in a reliable manner. So, did you take a history during examination? If anyone's relying on my notes for reliable stuff, I'm sorry. Everyone's notes are a bit dodgy. But we do know which tests you did. We do know which treatments you gave. We do know which pathology tests, which imaging tests. We do know whether someone got sent home or not. We can tell which fluids and treatments and flow rates for oxygen, whether you want a high flow or not. So these are all things that are written down, right? You can look at variation in care for head injury, and this is a PREDICT study that was done in recent years. Looked at 31 ADs and 3,000 kids with head injury. And this was a chart review, so we went back and looked at every chart and looked at a few things, and how many get a CT scan? There's a lot of variation, but the variation is consistent across different regions. So if you're in a tertiary hospital, you can go from 3% up to 15% of kids get a head scan. Pretty much the same in suburban hospitals and regional and rural hospitals. And really, what we know is that there's variation in CT head use, somewhere between 3 and 15% across the board. So whether your kid who bumps their head gets a CT depends on which hospital they go to. That's what we know at the moment. Asthma is a little bit all over the place, and again, we did an enormous chart review, 14,000 children with asthma over 18 EDs, looking at what we did in terms of escalating care. And this graph really shows that if you take hospital N over there, maybe 2% got either high flow or IV bronchodilators, whereas you look at hospital C, about 14% of kids got IV bronchodilators or high flow or a combination. So again, there's a hell of a lot of variation there. So this probably tells us that we don't know what we're doing, or the evidence isn't very good, or both. If we knew what we were doing and the evidence was great, we'd presumably all use it and do the same thing. So the fact that there's so much variation suggests that there's a gap somewhere. And why is that important? Well, there's an opportunity to improve and do the right thing. Because even if we're all doing different things, some probably cost more, some probably have more opportunity cost, which stop us doing other useful things for other patients. Another way of looking at variation is if we know there's something that we're recommended against. So these are the two things, like when do you really need to give someone IV bronchodilators, or which one you give, we don't know. There's other things you can look at an individual level, and we've had an electronic medical record in Monash for a few years now, and playing around with some of this stuff. I don't know how many people have seen funnel plots before, but essentially along the bottom we've got the number of patients that you as an individual clinician has seen. And on the y-axis we've got the proportion of children that have had this particular outcome. And these are children who are less than 1 year of age who've been given salbutamol or ipratropium for treatment of their bronchiolitis, which is recommended against, right? And each of those little dots is a different clinician. And the red dots are what we will call an outlier. So we've got an average rate of about 25%, which is probably too high. There's lots of grey dots underneath, which suggests that most people are doing okay. But there's a few people who are out there. Now, the people that are out there on this side, you'd worry a little bit less because they're not doing a lot of damage because they're not seeing very many people. But the people out here who are outliers are miles away from everyone else. Now, Fran's mentioned that audit and feedback doesn't work, or works a little bit, but you need the grand poobahs to sort of provide the advice. You know, if I got an email from my grand poobah along the lines of this, so you said 160 kids less than 12 months for the last couple of years with bronchiolitis. Australian New Zealand guidelines recommend against routine bronchodilators in this population. Across Monash Health, 25% of children receive this potentially unnecessary care, but your patients are getting this 90% of the time. It's a little bit awkward, isn't it? But it is one of those things that is actually possible right now. And that might work. Don't know. How do you tell? Well, does feedback work? Well, there's a Cochrane review that says that it does. And there's 49 studies, and the absolute increase in healthcare professionals' compliance with desired practice is up by 0.5% to 16%. So not a huge amount, but it's a little bit part of the studies and the way they're designed and everything else as well. So audit and feedback is more likely to be effective if baseline performance is low. So there's a lot of room to improve. A bit of audit and feedback probably helps. If it's delivered by the grand poobah, if it's provided consistently, so more than once, if it's verbal and written, if there's targets and there's an action plan. So, you know, is there a right way to do this? And, you know, NPS has been doing this for general practice for many years and other situations, and essentially you pick something that you think is important, you make sure there's evidence-based standards or best practice standards, you get some data, you provide feedback, you see what happens in response to that feedback, and you just keep going. So if it's worth doing, you can do it. Now, there has been some studies looking at feedback for individual providers in the ED, and there's some an example of what happens in the US. This annoys me because the screenshot they've shown is all about patients that are seen and how long it takes to see. The thing that they cut off down the bottom in the figure that they provided is how many CT scans you've ordered. But that's probably more about what I'd be interested in. Now, audit and feedback works. Can it be optimised? Can it be made better? There's the concept of an implementation science lab. What the hell is that? Well, you start doing something, right? You provide some audit and feedback. It may be that, yeah, you know, once a month at your medical staff meetings, yeah, we're ordering a lot of CTs. That might be it. There's your feedback, there's your audit. But then you can maybe try a different way of doing it. So, you know, this is what we've been doing for the last 20 years. What's our rate of CTs? We'll try something different and we'll experiment. And we find out that, oh, this new way of doing it, where you get these individual emails, makes a big difference. So that's our new standard, right? Now, you don't stop there. You see, well, if that's your new standard, you can now compare a new thing against it. Now, this new thing, you try getting someone in a little, you know, someone comes and slaps them every time they order something they don't need to order. You know, it's real time, it's immediate feedback, but it wasn't very popular with the staff. So you stick to that one, and then you try something else again. So the concept of an implementation science lab is trying to continuously improve your continual improvement. And this sort of gets to the concept of a learning healthcare system. You know, this is something that's bandied around by academics all over the place at the moment. It's very fashionable. But really, it is trying to do stuff better and using data to help you do that. There's lots of components, right? But essentially, you need, down the bottom, you need a supportive culture, you need resources to do it, you need data and systems and informatics. And you need also knowledge and evidence, and we need to build new knowledge and evidence when we don't have that. You need to have people engaged, you've got to actually believe that it's useful. You've got to look at your clinical data, you've got to think about how to fix things, and as new evidence comes in, you've got to be able to translate it into knowledge and practice. Measurement's not new. Doing things that are a little bit tricky aren't new. You might have heard of Galileo. He's a pretty clever guy. So measure what's measurable, but also make measurable what is not so. So just because we don't measure it now doesn't mean that you can't find a measure for it or do it. Has anyone come out of a shift and said, geez, that was busy, or that shift didn't feel safe today? Yeah. is there a measure for that? Is there something reliable that you could look at and say, when you're presenting to the coroner's court or whatever, it was actually a really horrible day, and this is this evidence-based measure of horribleness or lack of safety or workload or busyness, and really it's just a conjunction between acuity, rostering, skill mix, and a couple of other things. Why not develop a measure, So the interesting thing, sort of getting to the point of the talk now, sorry it's taken a little while, we have data within the ED. We've got demographic data, there's a radiology database, and then you can do a study where you get the ED data and the radiology data together and say, oh look, this is our rate of CT scans. It's not too hard, you just need like an Excel file and a couple of little commands. Pathology data, hospital-based data, length of stay, prescribing data. Okay, well, we talked about knowledge translation. New knowledge, changing guidelines, changing practice. So Franz mentioned status epilepticus, the concept study, new knowledge, there you go. We change guidelines, great. Does a change in guidelines lead to a change in practice? We'll get into our research mind just for a moment. We have a population, children with convulsive status epilepticus. We have intervention and control, post and pre-guidelines. And we've got an outcome of drug treatment. So you can do all this on the electronic medical record or within any database. You need children of a certain age. You need to find the ones that were fitting. So you have some combination of ED diagnosis or triage presenting complaint. You want to find the ones that are still fitting, so not the ones that had the seizure cluster and then sat there and looked okay. So whether you have a threshold of 12 or you have a threshold of 14 or 8 or whatever, you just need to pick something. And they were given some sort of second line agent. And there's your population, and that's all just through adding bits and pieces. And then from an outcome point of view, did they get an IV anticonvulsant? Everything's time stamped, date stamped, so you can work out when that happened. Did they get intubated? Well, it's usually pretty easy to tell from the notes, but you can bring that out, through electronic medical records. You don't need to look in the notes if someone's had ventilator obs. You don't need to look in the notes to see if someone got intubated if they got succinylcholine or rocuronium. So there's ways of designing your data collection to be all automatic. Did they go to ICU? And so we've got this concept. And then the next bit, which we haven't really done much on yet, is long-term. Now, there is an ED patient-reported experience measure which has been derived up in Queensland, which essentially brings together concepts around confidence in care, timeliness of care, patient engagement, the safety, comfort and privacy of care, and person-centred relationships. That's nice, give them a form, and in Victoria someone gets posted something like a month after they've been to ED and tries to remember what it was like. But we are set up that you can get something, the day after you leave ED, and you get a text message with the survey on it, and that can be linked back to your medical record. So if you cannot measure it, you can't improve it. And what we're trying to do is get to the concept of, we're aiming for this big red box down there. We're trying to get a central data warehouse, and you've got hospitals that have an integrated electronic medical record with everything there, and you've got hospitals that have different systems. But at the end of the day, we have the ability now to get all this information. We have the ability now to work out all of these things. It's not straightforward. There's a few barriers. There's data sharing, there's political considerations. Can this data cross state lines? Ethics and governance and ownership and funding and making sure that you don't single out one hospital that's doing a great job or a not so good job. Getting the right people involved in the planning and the extraction of the data is a challenge, and finding them is interesting. But when you look at what we do, which is a lot of things, you can actually measure a lot of these things, right? Some of them have well-established measures now. Times, tests, treatments, variation in care consistent with guidelines. 360-degree feedback is good for people that are working in various places. Patient flow, you've got time-based measures. Feedback from junior staff about how well they're being taught and supervised. It's possible, it's not that hard to do. Do we actually bring together data around rostering, skill mix, waiting times, workload, in some sort of index of safety? Well, we don't, but we could. Patient-reported measures aren't too hard to find either. It's just having the will to do it. So in an ideal world, I'd have something that looks a bit like this. It's a bit busy, isn't it? But essentially, you've got all this data flowing in, and you can use the data for everything. You can feed it back to hospitals, you can close the loop, you can provide things to do that, you can bring in patient-reported outcome measures and patient-reported experience measures, and you can do all sorts of interesting researchy things down the bottom. So, all of this is possible, and we're not breaking new ground. I mean, these guys have been doing it for 20 years. ANZICS has been doing this for a long time. There are many clinical registries out there. So really just, this is possible. It's not going to happen tomorrow, but some bits are already happening. And if you look at all the different clinical trials and all the different things that we're doing now, you know, data science and software has a lot of potential. And so really, the future is now, subject to funding. Thanks very much.
Thank you, Simon. It's a bit scary, the data stuff. I wonder if people have got some thoughts or questions for Simon to see where he's going to plug his brain into next.
I've got a question for Simon. One of the challenges with personalised data is it being used by management to bludgeon people into doing things they perhaps don't want to do or shouldn't be doing. How would you foresee, let's say if we had that personalised approach, great, we're prescribing less cases of salbutamol, but all of your colleagues are seeing 10 more patients a shift than you. Can you fix that, please?
Yeah, I think it's a really interesting question, and the risk is that we end up with the same thing as measuring appropriateness of hospital care by measuring how many people leave the emergency department. So the problem is a lack of clinical engagement. And so being involved and being engaged in these things is the best thing you can do as a clinician, because therefore this stuff will stay clinically relevant. When it becomes clinically irrelevant or management stuff, then it becomes bullshit. So you need to stick to stuff that's around patient care.
There's a question up the back there. Andy, you have to run. While you're running.
I'll run to Ben first, because he's closer.
Sweet, that's where you sit up the front. Thank you so much for that talk. I guess one thing that I found overwhelming is just the possibility, but also the practicality of that. And so I was curious if you or anyone else in the panel had any ideas about if there are any useful questions that we can ask already efficiently that we're not in terms of 360 feedback or our departmental performance.
So I think there's a whole separate discussion around each one of those. So departmental performance and 360 feedback are completely different things. And it's really about whether we as a individual or as a department or as an organisation or as a specialty value these things. So we at our place did a 360-degree feedback a couple of years ago, which was we had to pay for as an extra thing out of CME. It was really good. It was a really useful thing to do, but it's not necessarily something that everyone engaged in, and it's one of those things that it's, you know, I think they're fantastic and I think they're really good, but different people have different views on that. In terms of departmental performance, there are, you know, which bits of departmental performance. You know, there's lots of work around flow and waiting times and everything else. There's a lot less work on the nitty-gritty, and it is condition specific, because the care, as we say, to bronchiolitis is different to the care for head injury and so on and so forth. So at the moment, we don't have a nice set of things that we can just pull out and say, well, you know, this is the number of mental health patients that are being restrained in your department versus your department versus your department. But if it's important, we should develop the measure and we should do it. I mean, I think bronchiolitis is probably the easiest thing to look at. It is well defined, less than 12 months, little kid, wheezy, pretty hard to miss that, and don't do anything. So don't give this, don't do this, don't do this, don't do this, don't do this. So if you're doing these things, there's possibly reasons that you need to look at or things you need to look at. There's not a lot of things where everything's quite as clear cut, and so it might just be looking at variation rather than this is what you must or must not do.
Hi, I'm not blessed with a lot of patience, and I wonder if you could give me some advice on how to navigate the hybrid use of data, because working in Queensland, we're still waiting while the funding's being negotiated. We're still not on IMR, but some of us are. And how do we collect the data, and how do we bring it together, and how do we make it meaningful, and how do we stop reinventing the wheel?
I think the most important thing is to play nicely with others. And as Franz mentioned earlier, within Predict we've been very lucky that everyone sort of goes along the same way and is interested in the same things, and it's a very collaborative space. I think bringing different data sets together isn't as hard or as scary as it sounds. You just need someone who knows what they're doing. This whole project that I suggested costs probably about $300,000 a year to do, and that could work at a national level in terms of having the framework and having the system set up. You do need someone who knows a little bit about data science. I think that's the key. And then once you know that, you've got to work out your scope and your scale, and then you've just got to find people in each place. Once you've gained that, then it's not too hard. Happy to have a chat later if you'd like.
Can I ask one question as convener's privilege, Simon? If I ask 10 people in the room how to manage a UTI in a child, I'll get 11 different answers. How do you create a standard?
I think you need evidence to hang a standard on. I think, like with the asthma stuff that I presented, we have a lot of variation, which suggests that we don't really understand the ins and outs yet, and we need to get some better evidence. So there may be places that are currently evidence-free zones, and the data can demonstrate that, but it may be it's evidence-free zone, but the way I do it costs 6 times as much as the way you do it, and it involves 6 times as many needles as the way you do it. That's still stuff that's worth measuring. Or, patient experience trumps anything. So, if the way we're doing it in one way and there's lots of negative feedback from the patients, which we currently don't measure, therefore we seem not to really care about, if we get that information and get that data in a reliable manner and can link it to individual patients and individual care that's delivered, then you start getting into some interesting conversations.
And I'd just add, I feel that we use guidelines, but they need to be flexible and changeable, because otherwise we'll never evolve our practice when something new comes up. And the problem is, if you're being measured against a guideline adherence, you may end up in a situation where everyone stagnates and you don't get change in care. So it's a complex area to be involved in.
Yeah, I'll just comment on that briefly. I think you can't do this for everything. There's a lot of medicine which is evidence-free, but there should be, when there is clear evidence, we should at least try to use the evidence that we've got. So,
thank you very much. Can everyone thank Simon for a very thoughtful presentation?